Scott, how are you? Welcome to episode 9.
Hey, Mark. Doing great, thanks. And really looking forward to today's conversation.
Yeah, no, it's nice. It's nice to be able to get a couple of these sessions in during the summer when schedules get a little tighter. But we're thrilled. I'm thrilled about today's episode. And we get to take you back to some of your early career roots as a physician.
Yeah, really looking forward to that part, as you know, Mark. And but there's one big difference from in this therapeutic area and these sets of diseases from when I was practicing, and that's all the great new medicines that are available now compared to then. And so it's going to be fun to talk about that and how we can help improve patients' access to those medicines.
Well, great. Well, before we start, we have to do our disclaimer so that the views and opinions expressed on this podcast are those of the co-host and guest and do not necessarily reflect the views of our sponsors or any of its affiliates. So let's jump in. Scott, do you want to introduce our guests?
Sure. Happy to, Mark. We're pleased to welcome to the podcast today Julie Bach. She's a practice manager at a very busy rheumatology practice in the Midwest and deeply experienced in helping patients access their medicines. And so it should be a really terrific conversation. Welcome, Julie.
Thanks, guys. Happy to be here.
Julie, we always start our podcast here with a few moments for our guests to get a chance to introduce themselves and what they do and how they came to this. And we're always very interested to hear the backgrounds and how people got involved in drug pricing and access. And so we'd love to hear that from you.
Sure. Good morning. So my name is Julie Bach. I'm the practice manager of the Arthritis Center in Bridgeton, Missouri, which is in St. Louis. I've been at this job for 7.5 years. I don't have experience in healthcare prior to this job, but I've had some big jobs before. I think one of the things that's made our practice unique is that I didn't have the healthcare mentality of typical non-customer service that can happen in healthcare situations. I just advocate one patient at a time. And this medical office is a customer service organization. Mm-hmm. That's our first thing. And so our focus is on the patient experience and the patient outcomes. Our clinical team handles the patient outcomes. My administrative team handles the patient experience. We don't cross swords. We work in tandem, and we let the clinicians do the clinicians' work, and we will let the administrators do the administrative work, but the focus is on the patient experience. So we've always put it out there that if a referring primary care doctor or any referring physician mid-level has an acute new rheumatology patient and that patient needs to be seen, and that doc or doctor's representative calls my office, we'll see that new patient in 1 to 3 days. Mm-hmm. We are nimble, and we are here to serve patients, as opposed to some of the hospital-based rheumatology practices don't have that ability to pivot like that. And so they might schedule patients 6, 7, 8 months out. So we're really here to help. And that's what we've been doing for the last 7.5 years, and our growth has been pretty phenomenal. Of course, on top of that, it takes a whole lot of support staff. I have 24 support staff to support one rheumatologist.
Yeah, amazing.
And that's because of the payers and the pharmacy benefit managers and all of their administrative nonsense. So that's what it takes.
Right. Well, that's why we're here, and that's why you're here, and that's why we became familiar with you and your the practice and what you're able to achieve and the success you've had. And it's interesting because we started this episode with, that we were going to just sort of make it a foundational episode about physician office barriers, to access. And after having learned about what you've done and what you've achieved, we've changed the title of this episode to Fighting for Patients, because you truly are. Mm-hmm. And so, but before we get into, some of the challenges related to access and some of the things that you've done related to access, we do want to sort of set the stage if we could. Again, we want this to be also educational. So, because we do have listeners that are across the board with different stakeholders, including in Washington, D.C., so policyholders and others. So help us get started with sort of set the stage with understanding the physician office in terms of like the type of practice you are, the service patients you serve, the doctors that are prescribed, just sort of set that stage if you could.
Okay, so I have an independent single physician practice. We are in an underserved area of Bridgeton community. My patients are working folks, and they struggle to have their copay to come see us. So some of them are coming on public transportation. Some of them are, trying to get their medicine and maintain 2 jobs. So from that standpoint, I am literally serving the working class people and giving them concierge care for just the regular evaluation and management codes that we get from insurance companies. I see 25 new rheumatology patients in 4 days a week. Dr. Bach sees Monday through Thursday. He sees somewhere between 5 and 8 new patients a day. And each one of those patients are scheduled with him one-on-one time for 45 minutes. Like, I can't even imagine the last time anyone has gotten 45 minutes of physician's time. And in our case, the rheumatology patients are chronic, and the majority of our patients have more than 3 chronic diagnoses. So these are really medically fragile patients. They're hurting, and we can get them better. Right. We can get them better without surgical procedures and with medicine. Now, there's always an opportunity for surgical situations to be warranted, but not until the inflammatory issues have been addressed. We're saving patients from, back surgeries, from unnecessary operations on, plantar fasciitis and all sorts of things, because if you get these operations, you still have the underlying inflammatory conditions. So then patients are subject to multiple surgeries. So what we're trying to do is provide concierge level care for the working class folks. And I do that in a number of ways. First of all, I've got an amazing location. I've got a 4,400 square feet office on the ground floor on a hospital campus with private parking. I've got 9 exam rooms. I have Dr. Bach, and he has 4 mid-levels. So he has 1 physician assistant and 3 nurse practitioners. I have an infusion room where we give our patients their medicine. I've got 7 infusion chairs, and I have over 1,000, which is a huge number, infusion patients. That's a whole lot. This is a real small business here. So we're running about 28 to 30 infusions Monday through Friday, every day. 28 infusions. So I've got total about 65 patients coming into my office a day for office visits, for infusions, and for new patient consults. I have 2 ultrasound suites. So if we can get them out of the MRI suite and into the ultrasound suite and take care of what they need to take care of, it's kind of like a one-stop shop in the lowest cost possible. These patients don't have another $600 for an MRI, and if I can do it and take a peek at their knee and get an ultrasound guided injection, it's a fraction of the cost, and we treat symptoms. We don't treat MRIs. We don't treat, off whatever the films say. We treat off making people be able to do the things they want to do, getting them back to work, being able to be with their grandchildren. We have multi-generations of patients. I mean, I've got 19-year-old patients that their mother and their grandmother and their grandfather are patients at our practice. 50% of my referrals come from patients. That kind of goes to the good will and the clinical outcomes we have in our community.
Great.
Julie,
if I could just real quick,
ahead, Mark.
I just want to finish up. You mentioned 3 top diseases. What are the 3 top diagnoses that you're dealing with? And give us a couple of the top drugs that you're in the infusion center, just real quick.
Sure. So our top diagnoses are rheumatoid arthritis, psoriatic arthritis, or reactive arthritis. Okay. And those are kind of the 3 tracks. And then you have got your lupuses and the other ones. But those are the 3 primary. And so all of the patients typically start on, methotrexate if they're in those arthritis tracks, which is a very inexpensive drug. It can be oral or injection. And We typically start them on a weekly dose based on weight. And so they'll start with methotrexate, and Dr. Bach runs the AVISE panel on the lab so we can get a baseline of what's going on with the patient. But a lot of times you can't just, not a lot of times, all the time, you can't just use one clinical piece, because in an African American population, the HLB27 is not going to pop up in a rheumatology panel, right? So it doesn't mean that patient doesn't have rheumatoid arthritis. It's just one tool. So we look at, when we're working up for a rheumatology or rheumatoid arthritis, psoriatic arthritis, reactive arthritis, Dr. Bach is going to give a differential diagnosis at around minute 22 of his first 45-minute patient encounter. And he starts with a working diagnosis, and we get a bilateral ultrasound diagnostic of the hands on patients, because we can see the joint erosions and damage or lack thereof. But most of them have, tender and swollen joints. So if we have that baseline at the first visit, then we can make sure that we're not doing any harm over as we continue to treat. So methotrexate, the oral medicines and inexpensive medicines are obviously what we use first. Methotrexate, then you'll move on to like a sulfasalazine or, flutamine based on their labs. There's certain labs that have to be run before they can start that. And then we typically see a new patient back in somewhere between the 6-week and 2-month point. And then we'll go into, if the methotrexate and the oral medicines are working well, we're going to just keep that going. And most of them then will go on a 3-month follow-up. Then we'll move on to either a IV drug. Symphony Aria is probably the best drug we have right now for an IV. It's the cheapest drug. It's a quarter of the cost of Humira and Enbrel, which are self-injectable drugs. And it's a really great patient experience because it's only 30 minutes every 8 weeks. So a working person can come in, get their medicine, and get on to work for the rest of the day. And it's a really good patient experience because then they don't have to deal with the pharmacy benefit managers and scheduling their medicine to be refrigerated and shipped into them every month. And the costs are exorbitantly high for all of these medicines, but particularly the medicines coming and being shipped from, Express Scripts, OptumRx, and CVS. I mean, and everybody knows what a nightmare it is to call them on the phone. Even as a physician's office, I don't have direct access to any of these people. So that's kind of our first line. And the thing about rheumatology patients is they're very medically complex, and what works for one doesn't work for another. And what works for someone who's my size versus someone who's curvier, it's a sub-Q drug, 50 milligram drug isn't gonna make a difference for someone who's, curvier. That's why we really like to use these weight-based IV drugs like Symphony Aria. So everybody gets a customized dose, 2 mg over kgs, based on your weight. So we have really good patient outcomes. A couple things that we never do is non-medical switches, and that's really a huge problem right now with the insurance companies because.
I was just going to say,
I don't know if we want to go into that.
We will,
Yeah.
but let's sort of take it one piece at a time.
And just to a little bit more on that, which are the major insurers in your area, Julie, for your practice?
So Anthem, United Healthcare, and we actually are not working with Cigna anymore because of their administrative burden. So it's really Anthem and United Healthcare that are our primary, and then your Medicare, traditional Medicare, and then your Medicare Disadvantage programs.
Yeah. And I'm struck by the customer service focus and how strongly that comes through, and also just the size and efficiency of the practice that you've helped build and manage. And I'm wondering how that compares in your community to other practices. Has it got some others around that are doing things similar or very different?
So the independent rheumatologists in the area, there's 3 or 4 of them that are large like mine. There's several that are, smaller, but there is no competition in rheumatology. There's always more rheumatology patients than rheumatologists. So we're very friendly with our colleagues. But as far as a staffing ratio, I'm probably the largest one. And, part of that is because, my husband is the medical director. I'm the administrator, and he and I don't cross swords. He allows me to handle all the administration, and obviously I'm not tangling in clinical things. And I'm not afraid to put money where it needs to be put. I have a really gorgeous office. I like nice things. I want my patients to say, I want to be there. This feels good. I have great artwork, great chairs, and an amazing staff. Everybody on my staff wants to work there. I don't have any EORs. So I'm not tied to the hospital-based thing of it's going to take, 16 signatures to get rid of someone. If someone doesn't want to work with me, goodbye. I need you guys to serve patients.
Yeah. Just to follow on that before we get into some of the process stuff, Mark, the excess of demand, I'll say, for rheumatology services in this case, but specialty services generally, compared to supply that you described in your community, but which is prevalent, lots and lots of spaces, lots and lots of places. Just some thoughts on that. And clinician burnout during, and after the pandemic, and generally with, the environment that's out there and how that may contribute, and it's something that I know I worry about, and I know lots of people worry about these days.
For sure. Well, the rheumatology training programs are what they are, and coming out of this pandemic, when you've got residency and fellowships that literally were mostly virtual, okay, we're feeling the effects of the lack of education and the lack of experience, right? So we didn't close down one day during the entire pandemic because our patients needed to get their medicine. My staff needed to work. Lots of places, in particular, a hospital-based rheumatology place here, they're still doing virtual visits. Rheumatology is not virtual, folks. I need to have eyes and hands on the patient. I need labs. I need to see what's going on with them. Rashes pop up, things happen, and, they've got all these chronic conditions. So, there's a study out there that 50% of the rheumatologists are going to retire in 5 years. Wow. Okay. My husband is 63 years old. He's been doing this for 31 years. I'd like to be in that number, but I don't think we can leave these patients high and dry, right? And we've been trying to recruit a rheumatologist for the past 4 years. The training programs are putting out rheumatologists and physicians that are afraid to address pain controls and won't prescribe opioids to patients. Look, I'm not looking to have an opioid practice, but we use tramadol in a lot of patients. But the new fellows don't even want to touch that because it's flipped so far the other way. Right. And for my patients, they can't afford to go to pain management to refill a tramadol and then get subject to scheduled injections that aren't based on symptoms. So we try to do it all.
Yeah.
So in answer to your question, it's a mess. It is a mess for the future. I worry about my children's health care.
Yeah.
Well, speaking of messes, let's turn to access and the challenges you had. You've hinted at a few already, and I think that it's important to get into it. And our particular focus, obviously, is around access to medicines. So you mentioned your great administrative team. Just highlight just some of the steps that once Dr. Bach has prescribed the right treatment for the right patient, what steps do you take related to insurance and getting approvals? Just sort of highlight that real quick.
Sure. So these patients are so unique. Whatever my clinical team, Dr. Bach and the mid-levels prescribe, that's my job and my administrative teams to get that patient on that drug. I don't have any ability to do anything but what they want. Right. Okay. But then you have an insurance company and a PBM like Cigna and Express Scripts and Accredo that are saying, but wait, we don't want this patient to be on infusion medicine of Cimzia because it's too expensive, or really because they're not getting a big enough rebate and kickback. But here's the thing. If you're a childbearing age and you're trying to conceive a child, you can't be on any other rheumatology medicine except Cimzia. That's the only one that shows efficacy. So there are real solid reasons that my clinical team is writing medicines for a patient. And I don't care if it's an infusion drug, sub-Q drug, or an oral drug. Whatever they write, I'm going to the mat with, okay? Because there's real reasons to do it. I frequently have probably play in the most space in this pay-to-play formulary list. So all of the insurance companies have their little list of, that they will tell people is clinically the best medicine, but it's not. It is 100% based on what their manufacturers have paid them to play on their list. So, back in 2020, Express Scripts had a dust up, if you will, with Novartis, who is the maker of Cosentyx, which is a subcutaneous self-injectable drug. And Novartis apparently had a breakdown with them and said, we're not paying to play anymore. And so Express Scripts said, well, guess what? Nobody that's an Express Scripts patient, which is all of the Cigna ones for the most part. I mean, there's a couple that they go to other PBMs. They have to come off on a non-medical switch off Cosentyx sub-Q. Well, that's a disaster for a rheumatology patient. I mean, rheumatology patients, if they're stable, we don't change them. That's it. They have to stay on drug. And so Express Scripts, the PBM, sent out a 54-question prior authorization that had to be filled out for every patient on Cosentyx if they wanted to stay on it. Now, what physician's office is going to do that for every single patient on one single drug? They don't have the time, the staff, the bench strength to do it. Guess what? I do.
Right.
I'm the one who filled out all those things. And every one of our patients that was on Cosentyx stayed on Cosentyx. And interestingly enough, now here we are 3 years later, Express Scripts came back to Novartis and said, whoops, we need to have you guys on our formulary, and we know you won't pay. And they're not in a first position, but they're back on the formulary. So my hope is that pharma can stand with the physicians doing the work instead of the crooks at the pharmacy benefit managers.
Julie, could you elaborate a little bit more on the patients? What happens to the patients when they have to switch medicine like that? You said that you take somebody that's been stable and then you do a non-medical switch. What happens to the patients?
So Dr. Bach did 2 non-medical switches that the patients wanted to do in 2020 and 2021. And ever since those, we've never done another one. So what happened was stable infusion patients are on Remicade, okay? And then these 2 patients were United Healthcare, both of them. And United Healthcare demanded a non-medical switch to a biosimilar. So there's Inflectra and Avzola, right? So back in 2020, Avzola and Inflectra were not underwater. So now both are, and both have been. Inflectra, underwater means the acquisition cost is higher than they reimburse us, right? So, but the first thing we do is I talk to the patient and say, look, your insurance company wants you to do this. Dr. Bach doesn't want you to do this. What do you want to do? Because if a patient isn't going to stand shoulder to shoulder with me and advocate for themselves with their insurance company, and then I'm not going to tangle in them, okay? But we're also not going to write non-medical switches, so this probably isn't the practice for them because we have to do no harm as the base, and a non-medical switch is harm. So my 2 United Healthcare patients said, no, I don't mind. I will do a non-medical switch to Avzola and Inflectra, each one. Both of those patients had been stable for years on branded Remicade. Both of those patients had dramatic infusion reactions. One of them ended up being transported 911 to the hospital from my office, okay? Just because it's a biosimilar, it's not interchangeable. In fact, it's absolutely not interchangeable. And all of these patients react differently. I actually filed not 1, but 2 MedWatch reports with the FDA over those non-medical switches, and that became my prior authorization for the next to go back to therapy. But guess what happened on both those patients? United Healthcare said, okay, fine, go back to branded Remicade. We started branded Remicade, didn't work. Happens all the time. So now the employer paying the bill on this mess of this non-medical switch paid for the Avzola. I had a stable patient, an employee, on branded Remicade. They paid for the Absola and the Inflectra, which then we had to, throw out because we already mixed it and trashed that. They paid for the emergency room trip. They paid for us to have to rework up both of those patients. Then we go back to branded Remicade. That didn't work, so now we trash that, and now we have to work them up another time. So now both of those patients are they're on like the next 5 drugs. So they'll never be stable back on those old medicines. So after that experience, I don't give the patients an opportunity to say they're willing to do what their insurance company wants if they're stable. If they want to do, what their insurance company wants and they haven't started the drug, I'm happy to work through that with Dr. Bach, clinical team, and the patient. But there will be no more non-medical switches, and there have not been since those 2 experiences.
Julie, you mentioned the 54-page prior authorization, yet some payers have announced initiatives to reduce the administrative burden on physicians' offices. You're on the front lines, so have you seen any improvement on more, some simple processes to complete PAs? And tell us what it's like on the prior authorization front.
Sure. That's complete nonsense, by the way. That's window dressing. And it's not applicable in rheumatology. Everybody's, as a rheumatologist office, there's a huge target on our back because of the price of the drugs that we infuse and that we write prescriptions for. And you're hearing out in the media, it's this small subset, 5% of the patients are causing, 90% of the drug spend. That's a rheumatology patient, okay? It's not necessarily it's not necessarily a bad spend. It's just how corrupt the industry is. So all these middlemen are between the patient and the physician, and they need their piece of all of this thing. So with regards to your question, do we have less prior authorization since the insurance company's initiative? Absolutely not. Let's take Cigna, for example. They're our 54 question for Cosentex back in 2020. They came out with another policy called a 25 modifier policy. They've rolled this old dog out now 3 times and retracted it 2 days before it went into effect. That not only is it's another level of prior authorization on steroids, okay? A 25 modifier is literally designed to not pay the doctors doing the work. So if a patient needed 2 procedures in one day, an infusion and an injection, or an office visit and an infusion, you can't get that without a ton of paperwork. Wow. And it's essentially designed to deny the claim. And that's 100% Cigna. That's actually why we terminated our contract with Cigna over that policy. And I would love to sit down with people at Cigna and try to work through this and have them come to my office, even have a conversation with me about the patient experience. Because if you guys came to my office or Cigna showed up in my office, they'd be like blown away. They want this experience for their patients, but they don't want to pay, and they put roadblocks and broken glass in front of me doing the work. So are prior authorizations lightening up for rheumatology? No way. It's worse than ever.
Don't hold back, Julie. Don't hold back.
Okay. I know that I'm a little bit of a, I don't know if you know where I'm standing on this issue, but it is a dumpster fire, boys.
Well, Julie,
okay?
Are there any insurers or PBMs that are doing a better job than some of the others? And what, if so, what are they doing?
So, no, they're not.
So it's industry-wide.
It's industry-wide. I have to prior authorize tramadol, okay? I consult patients, buy this cash pay at a local pharmacy and forget it. I saw a 22-page fax yesterday to prior authorize tramadol. Yeah. This is a drug that's like $10 a month. But these patients, they don't understand it. The insurance companies, they want to control everything, And so we have to prior authorize Zofran. We have to prior authorize everything. So we're really in a bad spot here with insurance companies and the pharmacy benefit managers. There's not one single good thing that comes from them. They literally are middleman mafia.
Julie, if we could, though, now let's take it sort of out of the office. You've got a patient who's you've you got a prior auth and now they're on treatment. What are some of the patient barriers that you're seeing that could be high copays, could be other things? Like, what are you seeing there as a challenge?
So, on the sub-Q side and the oral medicines, and all of those need to come from a specialty pharmacy. Okay, there's nothing special about a specialty pharmacy. They're just, making it more difficult for us to get access to these drugs. But the biggest barrier to that is between the patient and the pharmacy benefit manager. So getting their drugs, they're mandated to get their drugs through OptumRx or Express Scripts or Accredo. You can't get these people on the phone. The patients have grave difficulty. These are working people. They don't have a job like you and I do that we can make a phone call while we're working and creating emails, okay? I can stay on hold for an hour with a pharmacy benefit manager trying to help a patient get access, but the patient doesn't have that time. And then there's all of these other nonsense of these pharmacy benefit managers have set up these lever programs that they have to contact the patient once a month and physically have a conversation with them before they'll ship their Humira, Enbrel, Cosentyx, whatever it is. And then they ship it and it's late or it arrives and it doesn't have any ice in it. It's 100 degrees here this week in St. Louis, Missouri. Or the package gets delivered to someone's neighbor's house and their dog chews it up. Like, there's all of these things that happen. And then we've got additional burdens of copay accumulators and then these interlopers that, have come in to sell solutions to self-funded employers like Vivio and Archimedes and that are doing like non-medical switches and they have no idea what they're doing. So the barriers to the patient, first and foremost, are dealing with pharmacy benefit managers and the lack of access. You cannot get someone on the phone. The shipping is a huge problem of the medicines. Then what happens is the patient fails. Let's say they fail Enbrel. The pharmacy benefit manager has a prescription for Enbrel times 3. If they get that little thing going on, they will continue to ship the medicine, but they won't ship it, if the patient isn't, once the patient has started to take it, if they come off of it, they keep shipping the medicine. And I call it fill it and bill it. They'll ship it to my office. I mean, I don't want any of this stuff here. They just keep shipping it despite the fact that the patient's off of it. So it's very inconsistent. A lot of these customer service call centers are in India. English isn't their first language. And the hours are really difficult for the patient. Right. So that's probably the biggest barrier on the sub-Q and the oral medicine side.
Julie, you mentioned copay accumulators and maximizers, and we had an episode earlier where we talked to a couple of experts on that. We've also been hearing about individual drugs being declared non-essential and therefore not covered, and attempts to route those patients then to the manufacturer's free goods program, their patient assistance. Sometimes they call it alternative funding programs. I'm wondering if you've seen any of that.
Oh, absolutely.
Yeah.
The alternative funding is a scam. Okay. It is, there's different employer groups that have been sold a bill of goods. I have one patient who's a riverboat captain, and in 2020, his employer had gotten bamboozled into a deal with Vivio, Vivio. They are an alternative funder, and they are trying to say that they're going to take over the rheumatology medicines, but they're all non-medical switches. Yeah. So I took it to the mat on every single one patient at a time. But I got the employer. I work directly with the employers. When I can't get anywhere with the insurance companies, and certainly you can't get anywhere with the PBMs, I go straight to the employer. They're the ones paying the bill. They have the best interest of their employees at heart. I have the best interest of their patients, of their employees. So why am I dealing with these people that don't want to talk to me, like Cigna and Express Scripts? So I go straight to the employer. I went to the employer and emailed, a big, huge packet. This is what Vivio wants us to do. I'm not doing it. Give me a single agreement to cut them out. And that's what I do. And I got that. And that patient is still stable on Orencia infusion therapy, And he's a little out of the box because he's out of town for 32 days at a time, and then he's back for 3 days. So I have to do his infusions a little bit off schedule, but I have a deal with the employer because that's the right medicine and the right time schedule for these patients. None of these patients are one size fits all. And I have a direct contract with Edward Jones and with to not have to use the pharmacy benefit manager. They don't even know that they're paying 3 to 8 times as much for a pharmacy benefit manager infusion drug as they can get it in my low-cost center. They've been so bamboozled by this. So I don't have to work with a pharmacy benefit manager for drug for Edward Jones. I don't have to work for it for Boeing employees. And those are all born out of advocacy and working one patient at a time. And we use Twitter, we use faxes, we use social media, we use reporting. I mean, the first time I did this, Dr. Bach took one of the patients on the news, and that was in 2020. And United Healthcare gave me a 5-year override to let that patient have her medicine in my office. So public shaming works. I mean, it literally is the new prior authorization.
Well, and I just admire what you're doing, and we're thrilled that you're here today to talk to us because I love, your ideas and your courage to take on some of these fights. And so thank you for what you're doing. But also there are manufacturer support programs, right? I come out of that industry and Scott comes out of the pharmaceutical industry. So help us understand your perspective on the manufacturer sponsored support programs, whether it's hubs or copay programs or patient assistance. What's been your experience with those programs? And again, don't feel like you got to say nice things. You can. We know you're gonna. Don't hold back.
Listen, the pharma copay assistance programs are vital. Okay, for the patients to have access to the drug. These are expensive drugs, and so if they can get the $5 copay card, but that's only good for commercial insurance. It doesn't work for the Medicare disadvantaged programs or the Medicare in a traditional supplement. But those patients can probably get their medicines if they have traditional Medicare and a supplemental plan. In the Medicare Advantage, which I call Medicare Disadvantage, the patient becomes the secondary insurance. They don't understand that. So if you're a rheumatology patient in my office, you probably don't have $3,000, okay? Most people don't. But if you have a Medicare Disadvantage program, you need to pay the first $2,700 to $3,200, depending on what Medicare Disadvantage plan you have. And the patients can't access the copay assistance programs because they have a government-funded program or government plan. As far as the patient assistance programs go, I've worked really closely with the folks at J&J, and particularly with Symphony Aria, and they're actually in litigation with a couple of these interlopers, like I like to call it. Save on SP and Payer Matrix, I've dealt with both of them, and I have single agreements with the employers to work outside of them. I one time had the Payer Matrix CEO call me up and say, "Who in the hell are you?" And I said, "Who in the hell are you? I'm just trying to take care of my patient here." Right. But at whatever it is, I'm drilling down, and every one of these cases are unique, and I'm working around them. So there's a company, the Plumbers and Pipe Fitters. They got sold, and they're complacent in all this too. They've got some TPA, a third-party administrator, that conned them into writing all of the biologics, carving all of the biologics out for their members, okay? These are hardworking folks. They don't even understand what that means. What that means is if they carve out the biologics, then I get a denial authorization rejected from the insurance company that they're partnered with, which let's just use Cigna, that says, oh, well, this patient doesn't have coverage for biologics, so they need to get free drug. There's a time and a place for free drug. And there's a time and a place for every drug in my office. But free drug is not infused in my office because the place for that is at the 340B hospital up the street. But the 340B hospital won't even take these people that are involved with Payer Matrix and Save on SP because they're draining the J&J patient assistance funds. If they can get a denial okay, that says you're not covered, then all of a sudden the manufacturers were saying, okay, give them free drug. The manufacturers are super generous. The problem is the pharmacy benefit managers and the interlopers. And then you have Payer Matrix or Save on SP turning around and telling and charging the employer, saying, okay, well, we got this free drug, so you owe us 25% of the list price of that drug. Right. They're selling free drug. So the pharma has now gotten wise to all this and changed the patient assistant programs and say, if you have insurance, you can't get free drug, which is very appropriate because we can't have, this is a whole nother industry and it's like whack-a-mole. Like there's all the time, we've got all of these interlopers coming up, Smith RX, Scout RX, Archimedes, Vivio, like they're literally just pivoting into pulling money off and making it, doing none of the work. So the patient assistance programs are vital to get commercial patients the medicines they need. But they've also been very abused by the interlopers and pharmacy benefit managers.
Do you see, Julie, any new kinds of programs emerging or new technologies? We've talked to a number of people that are optimistic about the role of information technology for the future in terms of making some of this navigation easier. Have you seen anything that's caught your eye?
No. Listen, this is not an algorithm disease, okay? This is so far from one size fits all. Mm-hmm. It's not even one size fits most. So, Cigna has got another lawsuit that because from the state of California, because they're processing algorithm denials and it's all over the place. 1.2 seconds for an algorithm denial from Cigna. Are you kidding me? Like they don't even have a live person, not even a pharmacy tech, not a nurse, not a mid-level, certainly not a physician, and certainly not a rheumatologist denying these patients. Like literally, it's just all of the AI in rheumatology. I haven't seen anything that's worth it because it's all based on algorithm denials, and it's not. These are very complex patients. Julie, it doesn't work. So I haven't seen anything.
Julie, you've been, again, you're on our radar because you've been involved in the local and national level and trying to make a difference. For policymakers at the state and the national level listening, what do you recommend they could potentially do to help improve the situation?
So I've actually testified on the Missouri Senate and Banking Insurance Company floor before in my home state here in Missouri, and I actually picked up a patient who lived 2.5 hours from me and drove her there because she doesn't have a car and she had to get rides. And she and I testified together. And it was such a horrible experience because we were the only two for the patients, okay, at this particular hearing. And there was like 9 lobbyists for the pharmaceutical industry from, Express Scripts, Accredo, OptumRx, PCMA, and they literally are telling these legislators and decision makers the exact opposite of how things are. And it's so disheartening. My message to the legislators and the people making the decisions is let the physician decide what the patient needs. Right. I mean, it's not. The pharmacy benefit managers, and they're just all in the news right now because it's finally caught on that they've put our independent pharmacies out of business, and they're probably looking to put me out of business. If I was them, I'd be looking to put me out of business too. But they don't have the patient's best interest at heart. The lobbyists don't. So my message would be, can you just let the physician decide what the patient needs and trust that? We took a Hippocratic oath, not the pharmacy benefit managers. Mm-hmm. I mean, they literally are wolves in sheep's clothing. And
if anything goes wrong, the doctor's the one to get sued, right?
Of course. We have all the liability and none of the decision powers. I can't tell you the last time I've done a peer-to-peer with a rheumatologist to a rheumatologist. It never happens. That's always a peer-to-peer is is not even a discussion of a clinical situation with a patient. A peer-to-peer is now being done by a pharmacist. No disrespect, because I love myself some pharmacists, but a pharmacist having a conversation with a rheumatologist with 30 years of experience is not a match. And there's a company called PHEP, which is the state of Utah's employee program. And there's a pharmacist over there that has been horrid. And she has I have her on all of my recorded calls. She's like, look, I know more about these medicines than Dr. Bach does. I'm like, you don't. You don't have 30 years of experience and all of this training, but they are so adamant, and they are making up the rules. The people that the insurance companies and the pharmacy benefit managers are making up the rules. So one size doesn't fit all, and that's what they're all about.
Wow. Well, Julie, it's great to see your passion. We always close by inviting our guests to share with us their ideas. If they had a magic wand, what would be your prescription for better access? So we covered a lot of ground here about things that could be improved. What would you focus on?
So I think that the very best thing for my prescription for access would be to have the self-funded employers direct contract with the physicians doing the work. I'm actually going to Wisconsin next week, and Wendell Potter is going to speak there. Wendell Potter is a whistleblower from Cigna from years ago. And I kind of have a corporate crush on him. I'm really looking forward to meeting him. But there's good and honorable insurance brokers, and there's ones that are not, okay? And so these self-funded employers are getting bamboozled into these plans that they have no idea what they mean. They're being told, look, if you don't mandate to Express Scripts and Accredo, your expenses are going to skyrocket. Okay, so that's actually not true. Okay, I'm a low-cost center. It's super efficient to infuse in my clinic or to be served in my clinic. So I think the direct contracting is the next step, because the physicians doing the work need to not be bogged down with more nonsense to do, with more prior authorizations. We're doing FMLA, disability paperwork. The paperwork that's why I have to have 24 people to support one physician. Practices don't have the ability to hire that many people and house them and do this work. So I would say my wish and my magic wand would say direct contract with the employers, and cut these middleman insurance companies out, and cut these middleman pharmacy benefit managers out.
I love it.
Yeah.
Well, Julie, thank you so much for joining us today. We were thrilled to have you on. You are a real inspiration, because you are a fighter, and you're fighting for patients, and you're fighting the fight to help us improve access. So thank you for what you're doing. Thank you for tell your team that thank them for what they're doing. We know how difficult that could be. And we really appreciate you joining us today.
I am delighted to be a part of the conversation, and I'd be happy to do anything again. And please follow my office on Twitter. We're STL Arthritis, because that's where we're calling out these insurance companies, and it works. Because if it didn't, I wouldn't do it.
Yeah.
Well, I've already started following you on Twitter, so you can count on that. Scott, you want me to go, or you want to go first today?
Why don't you go ahead, Mark? And what were some of the key takeaways from your perspective?
Did Scott freeze? So I guess I'll go first, since I think Scott, you froze there for a second.
Can you hear me now?
Yeah, we can hear you now.
Okay, yeah. I was just saying, why don't you go first, Mark?
Okay.
What were some of your key takeaways?
Well, I want to go back to the beginning. Every patient is one. It's a patient of one. There's no cookie cutter approach to patients. There's no cookie cutter approach to treatments. Every disease has maybe similar, but when it's into one person, how that person reacts is totally different. Bear with me. 2 is the obscene push and pull between who is the clinical decision maker. That is, there shouldn't even be any doubt about that. It's the doctor, right? Like, we don't want to go back to the days of the HMOs. We remember those days, don't we, Scott? And you know, Julie's right. You know, the decision makers at some of these payers, you know, they can't go toe to toe with the experts, and they shouldn't. We really have to let the power come back to the physician's office. Truly believe in that. The burden on the patients, we've heard it from all of our other episodes. It was very much, you know, a theme we've heard through the first 8 episodes in terms of the impact on patients and the burden on patients. I really liked how she brought out something new today, which was the communication and the shipping issues with specialty pharmacy. So anyways, before I lose my voice here, Scott, I'll let you sort of pick up and finish off.
Yeah, well, Mark, that's all great. And Julie, so wonderful having you here. I'm just first struck by, you know, what an amazing practice this is, and how much passion you and I know all your colleagues have for taking care of those patients, and sort of how lucky to, you know, really, if you need a practice like that, to be able to have one and be a part of that. I'm struck again by the overwhelming complexity of this, you know, crazy system that we've built. And especially the description of sort of the whack-a-mole of, you know, tactics that keep emerging back and forth. You try to get one thing solved, and, you know, another one is thrust in front of you. It's not an algorithm problem. I thought that's a very interesting insight. It makes it feel like it's complex by design, you know, frankly, that it's purposeful. And solving for that with, you know, technology or algorithm or whatever is going to be a challenge. I'm struck by the story about the non-clinical switches, the experience of that, and how hard that was, not only for the practice, but and for the employer group that's paying for it, but frankly for the patient. That would be months of setback in their clinical care that frankly, you know, was unnecessary. You know, it was that's just a striking description, frankly, of that. And then lastly, you know, this is back to a little bit to where I started, but it's clear to me, you know, the passion on the one side is matched a bit on the other side, has to be in this environment, by a degree of frustration with, you know, all the friction and everything that's going on, the craziness of it. And we mentioned about the limited supply of practitioners and the burnout. And I just worry about this, you know, continued conflagration of limited supply, demanding environment, burnout, friction, and all those kinds of things. And I think it's something that, you know, for the next generation, we're going to have to figure out better ways to deal with that than what we can't. Let's just piling on layer and layer and layer of this kind of stuff isn't the way. That's just making it worse. So anyway, amazing discussion. So fun to chat with you, Julie, and hear about life from your perspective, and really appreciate your time.
Yeah, and now that I have my voice back, I'll just say the last thing is her prescription for better access. Yeah, is a new idea that every physician's office should adopt. You know, I love it. I think that's the idea to go directly to the employer to get the carve-outs is a great idea. Every physician's office should be thinking about that. And let's just stop, you know, messing around with the burdens and go straight to the people who are picking up the cost. So love that idea. So Julie, again, thank you. Thank you for joining us. I want to say thank you to my partner, Scott, for our episode 9. This is going to be it for the summer. So we will be back after Labor Day. And with that, why don't I just say goodbye today? Because I seem to have losing my voice this morning. So with that, thank you, Julie. Thank you, Scott.
Thank you for carrying the message, guys. It's super, super important.